teaching undergraduate students and around 17 years of postgraduate teaching. She also has a fellow. She's a fellow in medical education and research, FAMA. She also has a diploma in travel health from Liverpool, and she serves as a resource faculty at PSC FAMA Institute and FAMA Philadelphia. She has also served as the convener of the MCI Regional Center at Govt Medical College, Kozhikode, 2010 to 2014. And she has been highly instrumental in setting up the skills and simulation lab at Govt Medical College, Kozhikode. And she's also served as the nodal officer during both the outbreaks of Nipah, both in 2018 and 2021. And she has also authored a textbook on community medicine, Principles and Practice of Community Medicine, currently in its second edition. Welcome, ma'am. And to present the current updates and guidelines, we have with us Dr. Nishath Rahiman, who's done an undergraduate and post-graduation family medicine from Govt Medical College, Kozhikode. And she's currently working as a family physician at her own clinic at Koduvally. Over to you, Dr. Nishath.
Very good evening to all. So at the outset, I thank Spice Route Kerala for giving me this opportunity to present a topic in this platform. I feel really honored to present before Dr. Asma Rahim, who is a very apt person to discuss the topic. And as you all know, we in this current scenario, we are facing this rabies. The rabies cases and the death are on the rise. And it is very important to know what are the current trends and what are the correct guidelines to treat or to manage a patient with animal bite wounds. So we'll go to the presentation. So is it?
You can start, Nishath. It is visible.
The topic. You know, rabies is a viral zoonotic disease, which means it is caused by a viral virus and it transmitted by animals. Now, it is
Nishath, you're muted. Nishath, you're muted.
So it is considered as a neglected zoonosis, which means in many part of the country, though it is a preventable disease, many part of the country that is not amenable to prevention. That is, the people are not giving due importance to prevent the disease. So the cases of rabies are in increase in many part of the developing countries. So rabies causes progressive as well as fatal inflammation of the brain as well as spinal cord. And the word rabies come from the Latin rabere, which means to rage or rave. So considering the world scenario, rabies is estimated to cause 59,000 human deaths annually in over 150 countries, with 95% of the cases occur in Africa and Asia. So we can see from this map that in most of the deaths are occurring in the Asian and African countries, while the disease is very rare in developed countries. So considering India is endemic for rabies, and the true burden of the rabies in India is not fully known. And about 1/3 of the death, that is 18,000 to 20,000 of death occur in India. Of 18,000, 20,000 deaths occur in India, that is 1/3 of the world deaths. And it is notable that 30 to 60% of the reported rabies cases occur in children under 15 years of age. So considering in Kerala, the cases were only 5 in 2020, but in 2022, up to 15th of September, the rabies deaths are 21. So there is an alarming increase in the number of rabies cases in Kerala also. So September 28th is considered as World Rabies Day by WHO, and the current 2022 theme is Rabies One Health Zero Death, which means the by 2030 the global goal is to have zero death of rabies by adopting One Health, that is considering the health of people, the health of animals, as well as health of environment as a unit. And by adopting the One Health, we can achieve zero death by 2030. So coming to the agent, the virus, as you all know, it belongs to family Rhabdoviridae, genera Lissa virus, and it has a specific morphology, a rod-shaped or bullet-shaped morphology, having a nucleocapsid. It is negative sense RNA, a partially segmented negative sense RNA nucleus, and it also has a lipid bilayer, outer lipid bilayer, and also glycoproteins. And this glycoprotein is responsible for generating neutralizing antibodies. So coming to the transmission of virus, how this virus is transmitted. And it is always transmitted by a bite or scratch. That means an intact skin cannot transmit the virus, but an intact mucous membrane can transmit, but the efficiency is very low. And sometimes inhalation of aerosols, virus-laden aerosols, can also transmit. And the saliva, tears are and CSF, the nervous tissue, are considered considered infective in a rabies case. But urine, blood, and feces of a rabid animal and milk of a rabid animal are not considered infectious. So this is how the virus is transmitted. And the animals, actually all mammals, warm-blooded animals can transmit the disease. But in India, the animals mainly transmitting the disease are dogs and cats. That is 99% of the rabies cases are transmitted by dogs in India. And the peridomestic animals like cow, buffalo, sheep, goat, pig, donkey, and horses and camels also transmit. And of course, wild animals like foxes, jackals, monkeys, mongoose, and bear also transmit the disease. But bats are not known to transmit disease in India. It do so in other part of the world. And domestic rats, squirrel, rabbit, and birds do not transmit the disease. And human-to-human transmission is also not well documented. So coming to the pathogenesis. So we are seeing that when the rabbit animal bite, there will be in that skin, the skin will be broken, and through that broken skin, the virus-laden saliva, it contaminates the tissue, and the virus get replicated in the muscle. And through the neuromuscular junction, from the muscle, the virus get transmitted to the nerve, peripheral nerve. And sometimes this transmission can occur directly, that is without the transmission through muscles, directly to the nerves. And from this peripheral nerve, that virus get transported to the retrograde axonal transport to the spinal cord. From there, it also gets replicated within the ventral horn neurons and dorsal root ganglia, and it infects the spinal neurons, and then it gets transported to the brain. And there will be infection of the brain neurons leading to encephalitis. From the brain, it can disseminate to extra-CNS sites like salivary glands via cranial nerves. So this is the pathogenesis. And the clinical course of rabies in humans, after the exposure, the incubation period, that is after the exposure, the symptoms appearing, the time taken to the symptoms to appear may vary. Normally it is 3 to 8 weeks, but it can be as shorter as 4 days and as long as a year. So the first symptom can be pain or numbness at the bite site. And also the patient may be having some prodromal symptoms like fever, anorexia, headache, malaise, etc. And after that, there will be stimulation of almost all components of nervous system, leading to acute neurologic phase. That is, the patient may be having anxiety, CNS signs, paralysis, hydrophobia, delirium, and hallucination. And depending upon the signs and symptoms, the rabies can be divided into 2 types. That is a furious rabies, in which the patient may be having a hyperexcitability, having symptoms like anxiety, hydrophobia, aerophobia, photophobia, and spasmodic muscle contraction. And sometimes there will be ascending muscle paralysis. That is, patient may be having ascending myelitis, leading to symmetric or asymmetric muscle paralysis. Flaccid paralysis, leading to paralysis of respiratory muscle as well as pharyngeal muscle, leading to death. And the patient may go to the stage of coma, having hypertension, cardiac arrhythmia, cardiac arrest, and eventually death. So rabies is a 100% fatal disease. So every patient with unexplained encephalitis should be questioned about the possibility of animal exposure in rabies endemic area, because many times the history of dog bite may not be clear. Will not be getting a history of dog bite. So every patient with unexplained encephalitis, we have to inquire about the animal exposure. And some of the differential diagnoses that we can have are infectious diseases like tetanus, cerebral malaria, rickettsial disease, and also some non-infectious cause, also like acute inflammatory polyneuropathy like Guillain-Barré syndrome, intoxication with poisons, drugs, alcohol, withdrawal, and rabies hysteria also are differential diagnosis for rabies encephalitis. So coming to diagnosis, a diagnosis is clinically and considering the epidemiological setting. But sometimes if there is any doubt, we can go for diagnostic testing. And the sample taken are full thickness skin punch biopsy, including the hair follicles for antigen detection. And saliva or throat swab or tears and CSF can be taken for virus isolation as well as antigen detection. And serum and CSF, we can look for neutralizing antibodies. And postmortem diagnosis is by needle biopsy and needle necropsy or autopsy of the sample brainstem or cerebellum for virus isolation as well as antigen detection. So we are seeing that it's a 100% fatal disease. No specific treatment is there, but we have to nurse the patient in isolation, isolate the patient in a quiet room, protected from external stimuli to prevent spasms and convulsions. And we can relieve anxiety and pain by use of sedatives and relieve spasm by antispasmodics, ensure hydration and diuresis, and sometimes intensive therapy may be needed in the form of respiratory and cardiac support. So likewise, in rabies in animals can also have 2 forms, that is the furious rabies and the dumb rabies. And like in human rabies, the furious rabies may have certain behavioral changes that patient, the animal may hide in the dark corners, will be aggressive, and there will be unprovoked bite and hyperexcitability. While in dumb rabies, there will be paralysis of the muscle. The voice will be very hoarse, that is, it cannot bark, change in voice barking. And in short, there will be change in behavior, that the dog become fearless, it bites unusual objects like mud, stick, and it has a tendency to wander around, and also there will be excessive salivation and change in voice. and leading, it may have paralysis, coma, and death. So these are the main behavioral changes or the changes, the clinical features that we found in rabies in animals, especially dog. So the most important part of this topic presentation is the prevention. So rabies is a preventive disease, and the most important part is the post-exposure prophylaxis. And this can be discussed under 3 headings, that is the management of animal bite wound, passive immunization with rabies immunoglobulin, and active immunization with anti-rabies vaccine. So whenever a patient comes to us with a history of animal bite, first and foremost thing that we have to do is the wound management. That is washing the area of animal bite thoroughly by with soap and water. So we have seen that virus has a lipid bilayer which is easily destructed by the soap, action of soap. So washing at least 15 minutes with soap and water is very important to decrease the viral load. So this washing is very important even if the patient attends late, because the virus can exist in the wound and replicate in the wound for a longer time. So even if the patient comes late to you, this washing part is very important. So often this part is neglected, and we'll go behind vaccines and immunoglobulin, and this management of the wound is often neglected. So this part is very important, washing the wound thoroughly with soap and water. And we can also apply virucidal agents like povidone iodine. But bear in mind that this wound should not be touched with bare hands. So next part, we have to decide on treatment, what treatment that we have to give the patient. For that, we have to examine the wound, and we can categorize the wound into 3. The first one is just history says they're just touching or feeding of animals and licks on indaxin. So we are seeing that indaxin does not transmit virus. So here the exposure is none. That is, the post-exposure prophylaxis is not needed in this case. But in second category, that is, there is nibbling of the uncovered skin, or there is minor scratches with oozing of blood, that is abrasion without bleeding. The exposure is considered minor, and here we have to have a thorough wound management as well as anti-rabies vaccine. And in third case, where there is single or multiple transdermal bites or scratches, licks on broken skin, or contamination of the mucous membrane with saliva, here the exposure is considered severe. And also bite by a wild animal is also considered category 3 wound, even if it comes under that is, even if it is an abrasion or minor scratch, it is considered category 3. Here we have to give, apart from wound management and anti-rabies vaccine, we have to give rabies immunoglobulin also. So the modern vaccines, that is rabies vaccine that is available, human diploid cell vaccine, which can be given IM only, purified vero cell rabies, purified chick embryo cell vaccine, and purified duck embryo cell vaccine. And these are the rabies vaccine available: Rabivax, Rabipur, Rabirab, and rabies vaccine. So there are mainly 2 routes, that is the intradermal route and the intramuscular route, by which the vaccine can be given. And a national rabies control program recommend the use of intradermal route, because here in a patient only 0.2 ml of the vaccine is used. So a single vial can be used multiple times. So it is more cost effective, as in centers where there is more number of animal bite cases. Intradermal route is preferred. That is in government hospitals or government center, intradermal route is recommended. So the regimen is called updated Thai Red Cross schedule. That is, it is a 2-site schedule. That is, we have to give 0.1 ml of the reconstituted vaccine on 2 sites. That is, 1 on each deltoid on day 0, 3, 7, and 28. So we have to give 2 into 0.1 ml, that is 0.2 ml of the vaccine, and have to give intradermally in the deltoid area. So when we give the deltoid intradermally, there will be a bleb will be formed. So we can ensure that the vaccine is intradermal. Next route is the intramuscular route, and the intramuscular route, here the whole of the vial should be used for a patient. So the reconstituted vaccine is used, whole is used for a patient. So it is not recommended for in centers where there is more number of patients. So it is in private hospitals or private clinics, this intramuscular route is preferred. And this regimen is called SN regimen. Here, 5 doses are given at a single site. That is 1 intramuscular dose of vaccine on day 3, 7, 14, and 28. So this is the intramuscular route. So we can. So when the patient comes, we have to already said that we have to examine the wound, and if it is a category 3 wound, we have to give rabies immunoglobulin also. So rabies immunoglobulin, it provides a passive immunity, that is active. The rabies vaccine will take time to act. So if the wound is very severe, that is the severity of the wound is very large, that is there is a high chance of transmission of disease. When the wound is very severe or there is a multiple transdermal wound, that the risk of transmission is very high. So we can't wait for the antibody, the vaccine to act. That means it takes time. So we have to provide passive immunity. And this is given by rabies immunoglobulin. It binds with virus and causes neutralization and loss of infectivity. So it is indicated for all category 3 exposure, and in immunocompromised, it is indicated for category 2 wound also. So there are 2 types of rabies immunoglobulin: human rabies immunoglobulin and rabies equine rabies immunoglobulin. So equine rabies immunoglobulin is a heterologous origin. It is produced from hyperimmune host serum. So it has a high risk of anaphylactic reaction. And the dose is 40 international unit per kg weight. When we convert it into ml, the doses weight into 40 by 300 ml. And human rabies immunoglobulin is a homologous origin, and it is relatively free from adverse reaction. The dose is 20 international unit per kg weight. Converting to ml, it is weight into 20 by 150 ml. So the whole of this calculated volume should be infiltrated to the wound. As much as possible, it should be infiltrated around the wound. And if there is any rest of the immunoglobulin, it can be given intramuscularly. So this vaccine, rabies vaccine and rabies immunoglobulin should not be mixed in a single syringe. It should be given, and also it should not be given on the same anatomical site. So there is a newer advancement in the field of rabies immunoglobulin. There is a monoclonal antibody variety of rabies immunoglobulin, that is Rabies Shield. It is developed by Serum Institute of India, and the dose is 3.33 international unit per kg body weight. So there will be some questions or some frequently asked questions while regarding the rabies immunoglobulin rabies vaccine. The most important one is the re-exposure in previously vaccinated. That is, if the patient is already vaccinated with a rabies vaccine, what is the approach? So here also the proper wound management is very important, and there is no need of rabies immunoglobulin. There will be antibody in the patient, so there is no need of rabies immunoglobulin. And the schedule is it's not 2 site, 1 site intradermal or intramuscular on day 3 and 0 and 3. But if there is a proof of complete post-exposure prophylaxis or pre-exposure prophylaxis within the last 3 months, it is said that there is no need of vaccine. So in previously vaccinated, only 1 site intradermal or intramuscular on day 0 and 3, and there is no need of rabies immunoglobulin. Next question is in immunocompromised individuals. So here also proper wound management is important, and rabies immunoglobulin should be given to category 2 and category 3 wounds. And this complete course of rabies vaccine by IM route, because intradermal route will not be effective in immunocompromised individuals. So the vaccine should be given IM route only. So next is when a patient misses a dose. In that case, the thing is the first 3 doses, that is day 0, 3 and 7 should be completed within 10 days to achieve effective immunity. So if there is a deviation of 1 or 2 days, we need not restart the schedule. But if 1 or more the doses are missed, we have to give additional doses to complete the vaccination. Next is whether the vaccine or the route can be interchangeable. So sometimes the patient may take intradermal vaccine from a government hospital or government setup on day 3 and 0 and 3, and then come for intramuscular injection, because the patient may not be amenable to other government institutions. So in that case, what should we do? This interchanging of this vaccine or route is not recommended, but under some circumstances this can be done. But in that case, we have to continue with regimen of the new route. Okay, then next doubt is whether the animal is vaccinated. The patient is bitten by a vaccinated dog. In that case, the post-exposure prophylaxis should be given irrespective of the vaccination status of the animal. Excuse me. Okay, so when the patient is bitten by vaccinated dog or cat, the complete course of post-exposure prophylaxis should be given, because we don't know the effectiveness of the vaccine or whether the animal has adequate amount of antibody titer. So, in spite of this wound management or vaccines and immunoglobulin, there can be some post-exposure failures that we see in these days, because some of the deaths in Kerala that occurred recently, it is said that the patient has taken the vaccine. So what are the causes, main causes for post-exposure failures? First one is the improper wound management. So this part is often neglected, and this wound management may not be adequate. For that may be the reason for post-exposure prophylaxis failure. And the delayed vaccination and not following the vaccine schedule, and not giving this rabies immunoglobulin category 3 wounds, and faulty injection technique, that is the storage and the transportation of vaccine leading to low potent vaccine and the vaccine failure. These are the main reason for failures in post-exposure prophylaxis. Next is the pre-exposure prophylaxis. So there are some high-risk groups like laboratory staffs, then veterinarians, animal handlers, dog catchers, etc. They need pre-exposure prophylaxis. And here there are total of 3 doses are given, 0.1 ml intradermal on one site on days 0 and 7, and the booster is given on day 21 or 28, or intramuscular full vial on one site on day 0 or 7, and booster on day 21 or 28. So this is a pre-exposure prophylaxis given to high-risk groups. So we are seeing the post-exposure prophylaxis as a preventive measure in rabies. And the next one is the prevention of rabies in dogs. So we are seeing that 99% of the human rabies cases are due to bites from infected dogs. So there is an alarming increase in number of community dogs, and the disease is more in these dogs because of mainly from spillage from wild animals. And also there is improper waste management leading to increased number of dog population. So this is the Animal Birth Control Rules 2021 by Government of India. It states that no animal can be should be killed, and there is the Act provide for sterilization and vaccination as a means of stabilizing or reducing the stray dog population to reduce the risk of rabies. So under this ABC or animal birth control, this animals can be divided, the dogs are divided into two categories, that is pet dogs and stray dogs. And the owner of the pet dog is responsible for its vaccination and sterilization, and there should be a proper license. And the stray dogs are taken care of by the local body or a committee, which is will take this nuisance dogs from the locality to dog pounds, where it is treated by a veterinarian if it is sick, and it is isolated, and then it is vaccinated and sterilized at this specific centers, and it is then taken back to the its original place. So this is the animal birth control that is we are practicing in Kerala also. So in short, the control of rabies in dogs can be achieved by mass vaccination in dogs, sterilization, and proper waste management, especially waste from the abattoir and the slaughterhouses. So the take-home message is the proper wound management. Should be done promptly for any animal bite wound, and timely vaccination and rabies immunoglobulin when required, and the proper waste management to reduce the number of dog population. These are important aspects of preventive measures in rabies, which is a fatal disease. Thank you.
Hello, hi Nishath, and hello everybody. Good evening to all. So it's been a pleasure to moderate. Am I audible? Nishath,
Yes,
Yes,
ma'am. Yes, ma'am. You're audible.
okay.
Audible,
Yeah.
audible.
So it's been a pleasure moderating this session because she has very crisply presented the topic of today, that is rabies current trends and guidelines. So this is a relevant topic and a hot topic of discussion today, and the media is taking a lot of advantage and hype over this issue because currently in Kerala, I mean, this year we had already 22 deaths, but out of that, about 17 deaths were in unvaccinated individuals and 5 deaths were in vaccinated individuals, unfortunately. And therefore, that is taking a lot of attention on whether post-exposure prophylaxis is working or not and what are the problems related to that. That is one aspect. Another point is that there has been a doubling or tripling of dog bites that has been reporting to our preventive clinic in not only in Calicut Medical College, but across Kerala. There's been a huge increase in the numbers of animal bites, especially the post-COVID situation. Post 2019, we have had this. And about 70% of exposures that report to our clinic is, we need to remember that they are all due to domestic exposures due to cats and dogs. And that is one situation where we should think that we need not, be worried about that all these are being inflicted by stray dogs, and the stray dogs have to be killed and culled and all. So 70% to 80% is actually from our own pet dogs and cats. And that's another aspect. And I think the relevance of Nishath's presentation today is that as physicians and general practitioners, we need to have an idea as on the rational management of animal bites, including how to counsel the patient or how to supervise wound management when a patient reports with animal bite. And you also need to be very thorough about the categorization of bites and should you refer or not to the higher centers. And I think, mostly what happens is that as some of the general practitioners, this not being a everyday phenomena, they're not very much sensitized, and therefore there seems to be quite a number of unnecessary referrals to our institution. So I think this webinar, this presentation is quite relevant today. So that is something, and so I think she's presented it very well, and so the topic is open for discussion. I can see a number of queries in the chat box. So Nishath, can we take one by one? And whatever you are finding it different, you can shoot it to me to answer. A lot of queries.
Intramuscular dosage. So the dosage is 1 full vial for a patient. That is, the diluent is normally 1 ml or 0.5 ml. In some brands, it is 0.5 ml diluent and a freeze-dried vaccine. So in that case, 0.5 whole vial is given to a single injection. So intramuscular dosage is the whole vial. Depending upon the diluent volume, it changes 0.5 or 1 ml. So is rabies vaccine recommended for rat bites? So domestic rats, it's not known to transmit the disease. So it is not needed, but wild rats like the mongoose, perichari. So in that case, we have to give rabies vaccine.
Shall I add to that? We get a lot of referrals for rat bites. So I don't think rats need to be treated. Rat bites need to be given anti-rabies vaccines. And there are other animals, as Nishath has shown, rodents and including mammals, like rabbits, squirrels are rodents again. So you need not give anti-rabies vaccines in normal case. But experts say that if it happens in forest areas, like among, as she said, mongoose or a bandicoot or any animals in the forest, in a thick forest, we all travel to forest these days, and you get a bite there, and especially an animal comes and attacks you, unprovoked bites. In that case, it is required. That's all. But otherwise, in the peri-urban area or where people are normally habitated, those areas you don't require treatment. Okay, we'll continue.
Questions: in previously vaccinated, 0-3 regimen is followed throughout life, or only if the patient has been bitten within 3 months? So when the patient is bitten within 3 months and there is a correct proof for this post-exposure prophylaxis after the incident, there is no need of vaccine within 3 months. But after 3 months, I mean, I think it is lifelong.
Yeah.
Lifelong, we have to give 0-3 regimen.
Yeah, you're right. That is, if we have taken a full course of anti-rabies vaccine, having had a previous exposure, then next time you get an exposure, all you need to do is anytime, just 2 doses would do, 0 and 3, either intradermal or intramuscular.
Wouldn't it be advisable to check the titers in that case? Antibody titers?
Yes. It is a bit costly, antibody estimation, and we do not have many centers which are doing it. So let's take Calicut. I think a few centers like Dr. Mummy's lab, and they're sending it to Mumbai. And it takes about 1 week for the titer results to be, to get the titer results. It's about 3,000 rupees per test. So only, it is not everybody's cake. You can't ask, a person with a moderate income or a low income family to test the titer. So presently, what we advise is that for high risk personnel like veterinarians and lab workers, antibody titers should be tested, and that rests upon the employer.
Thank you.
Okay.
Next question.
Okay, let's next one. Yeah.
This questions are same, so I'm skipping. Then, multiple wounds involving epidermis extending up to dermis, but full thickness of dermis is not involved. Class 2 or 3. How
Yeah.
we can know that is dermis or epidermis is involved? I don't know. But
Yeah.
the thing is, if there is just a scratch without any blood oozing out, that means we can without any just blood is visible in the scratch mark. In that case, we can consider category 2. Am I right, ma'am?
Yeah, it is superficial scratches. That is, you can see that there is a superficial scratch and there is some kind of erythema and all usually associated. That is category 2. Once there is a break in the skin with bleeding or there is a deep puncture wound or a bite mark, then it becomes category 3.
Sorry to interrupt. What I would suggest is that if there's a confusion between 2 and 3, I think it would be better to go with category 3 and go ahead with the immunoglobulin to be on the safer side, if I'm not wrong.
Yeah, if you have a confusion with category 2 and 3, then, if it's a domestic animal, you can take a call and, just ask if the animal is vaccinated, because domestic pets are required to be vaccinated now. In that case, you can safely go ahead with category 2 if you've got a doubt. But otherwise, if you have any suspicion, then just refer to higher centers if you're not very sure about it. Because anyways, I don't think in a private clinic or a general physician's clinic, you're going to give ERIG or HRIG. I'm not sure. Do you do that? No, I don't think. In hospitals, they do. But otherwise, we don't.
Next question is, how long we differ immunoglobulin previously vaccinated individuals on re-exposure? We do not give patients immunoglobulin for re-exposure because already the immunoglobulin is there in their body. Though the titer is low.
Yeah, please continue. See, the thing with pre-exposure prophylaxis is, suppose you have a domestic pet and you voluntarily choose to take pre-exposure prophylaxis. That the schedule is, as Nishath has said, 0, 7, 21 or 28. Then you are supposedly you are protected from rabies. So next time you get any bites, then you just need to take 0 and 3, and there is no need for immunoglobulin. Yeah, next one.
Next question. Any test to detect rabies in animals?
Oh yeah, you have said, no? You have...
Saliva can be taken for virus isolation and antigen detection. And in post-mortem, we can take the brain tissue for virus isolation, CSF for antibody titers. Next is, can we check antibody titer after pre-exposure prophylaxis or post-exposure prophylaxis? How long after last dose is recommended? Cost and availability of the test.
Yeah, I've talked about that. Yes, 3,000. But if you want to check antibody titers, then you need to do it 14 days after the last dose of the vaccine. You have to check 14 days after the last dose of the vaccine, or any time you want, you can check. But the thing is, naturally, the antibody titers will start falling. After 1 or 2 years, there is going to be a dip in the antibody titer. But remember, there is a strong immunological memory, and that is the theory behind inactivated vaccines and boosters. So anytime you get an antigenic stimuli, naturally your immune system will recognize it and it will trigger an immune response. Absolutely no problem. So that is something about taking an ARV pre-exposure.
Is it advisable to observe the dog for 10 days, and if dog is healthy, skip the last vaccine dose on day 28? So in case of pet dogs, we can do this. Pet dogs, we can observe the dog. We can observe for any change in behavior, and can very well say the patient, when the dog die within this 10 day, we can be sure. But in case of stray dogs or community dog, we cannot observe the dog. And here we can skip the day 28 and can convert the whole schedule to pre-exposure prophylaxis. Am I right now?
Yeah, there one thing is, if you're taking an intradermal route, what was that question? What they asked? One more. Can you just repeat once more?
Is it
What you said?
advisable to observe the dog for 10 days? And if dog
Okay.
is healthy, skip the
Yeah.
last dose.
Usually what we do is we do that with the intramuscular schedule. If the person is taking an IM schedule, then you might as well ask the patient to watch the dog or cat for 10 days. And if it is alive, you can skip that dose and convert it to a pre-exposure schedule. We don't do it that in our hospitals, because in our hospitals, we usually do not convert a post-exposure prophylaxis to pre-exposure, but they can do it on their own. And but for intradermal, what we do is we continue with the whole injections till the last dose. Okay.
How many hours post dilation can the vial be used for ID doses? It's 6 hours. If the patient presents late, should we still go with the vaccine and immunoglobulin? I don't know the actual time period, ma'am.
Yeah, whenever the recommendation is that however late the patient presents, since the incubation period of rabies virus is variable, even if the wound is healed, we do whatever is required. We inject and infiltrate the ERIG, assuming that you may be able to save the patient, because we don't know whether the virus has got fixed to the neurons, to the nervous tissue. So that is something we go ahead with the routine, however late he is.
Is there any difference between the vaccines taken before and after 2004? I mean the vaccine immunogenicity difference.
Earlier we used to take the neural tissue vaccines, which used to be given around the umbilicus. When I was doing my internship and all, we used to give 14 injections around the umbilicus, and they found that neural tissue vaccines is not recommended by WHO, and it's actually banned. We don't use it now. So then came the cell culture vaccines. That is the one which we are using. And the immunogenicity has been the same for all vaccines which we are using now. There is no difference in immunogenicity. Probably the route of immune response is different. In the sense, intramuscular vaccines elicit immune response basically through a humoral pathway, and the intradermal elicits immune response through a cell-mediated pathway. That is a major difference. But in terms of the seroconversion, it is not much different.
Next question is drugs to be avoided while taking IDRV. Since the IDRV is an inactivated vaccine, no such drugs to be avoided.
I think I need to add something to that. One thing, when a patient comes to you and when you are there in a government hospital, before giving IDRV, take a clear history whether the patient is immunosuppressed, like an HIV patient or so, whether he's having steroids, whether he's on chloroquine prophylaxis for malaria, or whether he's on CKD or cancer treatment. In that case, never ever give intradermal. For all immunocompromised, then we shift to the intramuscular schedule. So you have to ask that question while giving IDRV. And also note it down on your OP ticket that this is why IDRV is not advised. IM route is preferable.
If the patient has taken a COVID vaccine and presents within a week of COVID vaccine, does it alter the rabies vaccine schedule?
No. The latest recommendation is that even in spite of having taken COVID vaccine, you can take rabies vaccine, because it's after all an inactivated vaccine.
Next question is how to continue IDRV schedule if the patient skips 1 or 2 doses. We have to give additional booster doses.
Yeah, that is what you said, right? You need not restart. The most important thing about post-exposure schedule is the first 3 doses. Always make sure that the first 3 doses are not skipped. But if the patient skips 1 or 2 days, that's not a problem. So what we normally do is we do not restart, but we continue in that same interval. And, just try to tweak the interval a bit and we continue the dose. But if the patient misses, let's say, 2 doses, but only 1 dose has been taken, it is actually, we restart the vaccination and continue with the same.
Next question, IDRV in pregnancy and children, same dose and schedule. So irrespective of the weight, body weight or age, or whether the patient is pregnant or lactating or old age, the vaccine has same dose and same schedule. Need not change. Next question, ma'am, 72 hours late presentation of any bite needed immunoglobulin. So we have discussed it earlier. You have to give everything irrespective of the time period.
Only thing is there to add on. Suppose you've started vaccine and on the 7th day, I mean, if the patient reports later than 7 days, then we don't give immunoglobulin. Animal dies, the patient says that the animal dies, and then and they report 7 days later, because the vaccine starts working. And then if you give immunoglobulin, we presume that there is going to be some interference in the antibody formation, and therefore that is not given.
This vaccination is mandatory if the person drink water which the dog had already drunk.
Shall I take that? Shall I answer that question?
Yes, ma'am.
Yeah, I think there is no need. One important point is currently the recommendation is that even if you drink, this milk of a rabid cow, such cases come to our clinics. You don't have to take post-exposure immunization. And there is a reason behind that, because our gastric juice is acidic and it cannot survive in an acidic environment. And so they say there is no documented transmission anywhere in the world of having drunk rabid cow's milk. Same thing is for water also. You don't require, but in reality, what happens is the person who has drunk would be so apprehensive and frightened. So what we do is we give a placebo-like vaccination. Either we ask them to purchase in the hospital when they come, we ask them to take it voluntarily, or we give a pre-exposure prophylaxis schedule to them and record it, because mostly they'll be too apprehensive and we will be unable to convince them.
When a patient comes for IM regimen, after starting ID regimen, should we just continue with the rest of the regimen or restart the whole IM schedule? So we have said in the presentation, we can continue the newer schedule. We can continue. Need not start from the first.
Yeah, that is the current WHO position. There is a WHO position paper 2018. And it clearly says that you need not, even if switching is not advisable, but if such thing happens, then don't worry, you just continue with the schedule.
So I think questions, no more questions in the chat.
Ma'am, as a take-home message, what do you have to say? How do we prevent rabies deaths?
preventing rabies deaths, if you ask me, the main thing would be license your domestic pets, immunize your domestic pets. That is most important. Second one is immunize all the stray dogs, because in Goa and various other states like Sikkim, they've got a very successful model of eliminating rabies. And how they have done is something like a herd immunity in polio. They have immunized more than 70% of stray dogs, and they've been able to successfully eliminate rabies deaths in those states. So we can do that too. That is the second. And third one is wound washing. What happens is when those grievous injuries happen due to stray dog bites, people are so scared that they do not wash the wound properly. And that is the cause of the deaths which we have noticed in the 5 cases which has occurred in this year. Most of the wounds were on the head, scalp, neck, near the eye. So there's been a direct entry of the virus through the cornea and the optic nerve. And also a direct inoculation, that is a direct fixation into the nerve in deep bites. And the wound washing, there's a delay in reporting to the hospitals. And they've been running around quite a few hospitals before they landed in medical college. And in most of the centers, it is just a self-report that we get, okay, wound has been washed. And that's by the bystander. And the bystander himself or herself was so fearful of washing the wound with bare hands. They don't wash the wound properly. So there are 2 types of washing we can do. One is mechanical flushing of the virus under tap water. So there is a mechanical action in which all the virus is displaced from the wound. Second one is inactivating the wound or using soap, because it's a lipophilic virus and the lipid coat gets dissolved when you wash with soap, and about 95% of the virus can be killed at the wound site if you wash it properly. And the third is neutralization of the virus with the rabies immunoglobulin. So these are the 3 mechanisms by which we can use. So if we create awareness among people, okay, don't worry, have a first aid box in your homes. Wear a glove and wash the wound properly, because the victim is under a shock and they won't be able to wash it properly. So whoever is tending to the victim, the bystander, wear a glove and make sure that you do not have any injuries on your hands, and then wash the wound properly, especially in wounds on the face and head. There are bleeding wounds, and when we talk to the patients and the bystanders, they said, no, we don't want to touch those bleeding wounds. And that is exactly the reason these deaths are happening.
Thank you so much, ma'am.
Yeah, thank you.
I now invite Dr. Vishnu to officially conclude the session.
Yeah, there is a last question, I think. Missing the old Lifebuoy red soap. Yeah, that's right. The Lifebuoy soap is still there in the market, I think. But I think there is a carbolic soap and so many soaps, Dettol soaps are all available, but any soap would do, because the soaps have got, it has got the ability to neutralize that lipid coat, dissolve the lipid coat of the virus.
Ma'am, just one more question. When to close deep wounds by rabid animal bite?
Yeah, when to close deep wounds by rabid animal bite? Yes, that's a very good question. Normally, we don't advise suturing of the rabies wound immediately, because we need some time for the rig, that is immunoglobulin, to penetrate into the wounds, into the myocytes, and prevent the rabies virus, neutralize all the rabies virus. So if you are again inflicting more punctures or wounds, you'll be driving the virus deeper into the muscle tissue. So we don't want that to happen. So what we do is, if there is a bleeding vessel, then we tend to we ask the surgeons to tie the vessel and apply a bandage and do a secondary suturing or a delayed suturing, probably hours after the immunoglobulin has been given. Some hours, let's say 12 hours after the immunoglobulin is being given, has been administered. In some cases, even secondary delayed suturing, that is 7 days later, that would do. And if it has to be sutured, we advise minimal sutures for the time being. Okay, Nishath, I think somebody has complimented you for that excellent presentation. I too agree with that. It has been a very informative presentation.
Actually, ma'am has helped me a lot to prepare slides.
Thank you. My pleasure.
Good evening, all. Dr. Vishnu here. So it was a very wonderful session by Dr. Nishath, and on behalf of Spiceroot Kerala team, I would like to extend heartfelt thanks to Dr. Nishath for taking this session. And I would also like to thank Asma Madam for taking your valuable time and coming over here and having a wonderful discussion and clearing all the doubts. I think we had around 80 odd participants attending this session from all over India. And I would like to thank all the participants on behalf of Spiceroot Kerala team. Thank you all.
Thank you.
Thank you.
Thank you so much, ma'am. Good night.
Okay, thank you. Bye. Good night. Shall I take a leave?
Yes, ma'am. Yes, please. Thank you so much.
Okay. Thank you. Thank you, Ali.
Yeah. Bye.
Thank you, ma'am.